Hi everybody. Now the purpose of this video is to show you the findings of a diagnostic laparoscopy in a patient who presented to us with abdominal distension with significant weight loss in the last 6 months, and on ultrasound abdomen it is suggestive of presence of ascites with multiple fluid levels. Now this patient was posted for diagnostic laparoscopy on suspicion of abdominal COX, and in this video what we are going to see is a raw video, and you will be able to see the exact finding after insertion of first laparoscopic port. So just I'm trying to go out, and here you can see this is my same video. I'm going to make it public now after explaining this video to all of you. The heading is here. You can see the diagnostic laparoscopy first port finding in abdominal COX. Here you can see this is the trocar. This is being inserted, and I'm just playing the video. I would like to explain it to you. This is the patient, the abdominal part, the intubated, and I have inserted the first port inside the abdomen through the periumbilical area and the connecting tube for pneumoperitoneum connected. And here you can see all these things. These are basically the ascitic fluid, right? I'm just playing this private video, one of the private video that is present on the learner's domain, just to make it public. I'm just explaining it to you. Here you can see the objective lens of the telescope is being cleaned, and this is the ascitic fluid, the gallbladder, the liver. This is how this ascitic fluid of tuberculosis looks like, and the various additions. There is the granuloma, the white one. Here you can see this one, right? This is the perihepatic additions. On the right side, you can see the tubercles over the liver surface also. If here you can see, yes, very clearly visible. Now these are the sites from anywhere from which we can take the biopsy to confirm the diagnosis for tissue diagnosis. You can see the tubercles present over the peritoneal layer also. Here, yes, these are tubercles, very clearly visible. The falciparum ligament, again loaded with tubercles, right? And this is the left part, is the pericardium, the transmitted pulsation you can see through the diaphragm, the cardiac pulsation. This is the left lobe of liver, and you can see each and every corner of the peritoneal cavity is having tubercles. This is stomach, right? This is stomach, the greater curvature, the stomach. slightly distended. This is again the cytic fluid, the left hypochondrium area, right? And here somewhat there is spleen. Again tubercles on the left inside wall of peritoneum on the left side. Here you see, after insertion of Ryle's tube by the anesthesia team, Ryle's tube was there, but it was not correctly placed. Now it is correctly placed, and now you can see the stomach. Previously it was distended like this, right? And after insertion of Ryle's tube became like this, okay? The stomach. Now after decompressing the stomach, now you can see the left lobe, liver, the cytic fluid, and very clearly, right? So starting from the cecal area, going towards the hepatic area, then traveling towards the spleen or the left hypochondrium, we have seen the almost every features of abdominal tuberculosis that is mentioned in theory books. Here again, and what is required after this diagnostic is to put another port, and through that port a suction should be introduced, and this is what is exactly required in this patient at this time. So here you can see I'm just pressing the anterior abdominal wall from outside, and impression you can see the inside with the help of telescope, right, in the probably infraumbilical area. Yes, through infraumbilical area I'm going to put another port. You can see the impression of inferior epigastric vessels here. So always try to prevent the injury to these vessels. Here also tubercles are present, right? I'm just now here probably we are inserting, let's see, probably 10 mm, the tip of this trocar sheath, the port sheath along with the trocar. This is circular one what we are having, although the beveled edge can be used, and I think better than this circular one, but this was available in the trolley, so we have used it, the circular one, this sheath of port. And after putting this 10 mm port, we'll insert a suction cannula inside after using a reducer. This is 5 mm suction cannula. The idea is to slowly decompress the abdomen of this patient. So we took our time, proper time, to just take out the cytic fluid almost completely, and like this you can see sucking it out, and as we are taking out this cytic fluid, everything, the other structures are clearly visible now. The ascitic fluid present in the dependent area in the pelvic cavity. Yes, now you can see the small intestine impression also. Okay. Right. And probably due to somewhat inadequate white balancing in this telescope at this time, you can see the color of the structures that is not natural probably, as per my understanding. So this color of the structures can be corrected by doing white balancing whenever we are taking out the telescope, and before inserting it inside always we are supposed to do white balancing. The white balancing concept we will study in some other video. So after sucking out the cytic fluid here, now you can see the lesions over the small intestine, the loops, the greater omentum, just like a cake-like, pancake-like appearance. Cake-like pattern is there, thickened omentum. Gallbladder with meso gallbladder, vein studded with tubercles, and again you see the cytic fluid again that is present just on the right side of the gallbladder. Here now you can see this is now spleen is visible now. Previously it was not visible. After decompression of the stomach and sucking out so much of cytic fluid out, now we can see the spleen in the left hypochondrium. And again there is still more cytic fluid present, but we are waiting for the patient to be resuscitated for the third space loss in this patient, and then only we can take out some more. There is the liver, the left lobe, the gallbladder, the right lobe, the stomach, and this is the pericardium, the pulsation transmitted, and now we want to suck out this fluid, the cytic fluid present in the perisplenic area. So in this patient, don't try to damage the spleen, just be careful while sucking it out. Trauma to the spleen should be avoided. May be very fragile in these type of patients, and even you can see the lesions over here, perisplenic collection. Even without taking the biopsy, diagnosis is suggestive of abdominal cox, but yes, for documentation and for confirmation, we'll take the omental biopsy as well as the peritoneal biopsy and we'll send it to the pathologist for confirmation. And in this case, we took the peritoneal biopsy and omental biopsy, and the pathologist report was suggestive of tuberculosis, right? So this was the exact the first port. After first port insertion, these were the findings. Again you see in the fresh the cytic fluid appearance is there, and we have again taken it out, and this is the appearance of the peritoneal side of anti-abdominal wall. Yes, and I'm using just two ports. One is for a telescopy, that is laparoscopy, and another one is for suctioning and all these things. Okay, so this was the finding that usually we can see in cases of tuberculosis, abdominal cox, the diagnostic laparoscopy. Thank you so much. Take care. Bye bye.